Gonorrheal arthritis. Gonorrheal arthritis, or gonorrheal rheumatism, as it is commonly called, is the commonest type of metastatic gonorrhea. Occurrence. Gonorrheal rheumatism is said to occur in about 1% of persons afflicted with urethral gonorrhea. Children are particularly prone to it and may develop it from slight local lesions. Thus, Kimball found 10 cases of gonorrheal arthritis among 70 children. Women are much less often affected than men, doubtless because they lack seminal vesicles. Northrop reports 230 cases in the male to 22 in the female. It has been noted by Fournier as early as the 5th day after the onset of gonorrhea, but is commonest between the 3rd and the 5th week. It may occur at any time while the patient harbors gonococci. Certain cases show a marked tendency to relapse of joint symptoms with each new attack of gonorrhea. Fournier and Keyes Sr. have each recorded an instance of 4 such relapses in a single patient, and Brandeis has seen 6. Etiology. Retention of pus in the seminal vesicles is believed to be the usual cause of gonorrheal rheumatism. We do not yet know how broad this rule may be. Distribution. The lesions are often polyarticular. Among Northrop's cases, 76% showed involvement of 3 or more joints. Moreover, synovitis, bursitis, and the other lesions of systemic gonorrhea are often associated with joint lesions. The knee is the joint most frequently affected. 2/3 of Fournier's 120 cases, 1/3 of Finger's 375, 7/8 of Boneman's 278 cases. Northrop's statistics show gonorrhea of the knee in 91 cases, of the ankle in 57, of the foot in 40, of the wrist in 27, of the heel and toes in 21, of the elbow in 18, of the hip and shoulder 16 each, of the hand in 11. The association of gonorrhea with spondylitis has been suggested by Bouchard and Schutt. Pathology. Gonorrheal arthritis is but a single expression of a general infection. Like other forms of septic arthritis, it depends upon bacterial localization, either in the joint itself or in the articular extremity of the bone. Hence, the 2 distinct types of the disease, gonorrheal arthritis and gonorrheal osteoarthritis. Clinical types. The onset may be acute or subacute. If acute, the inflammation begins like an attack of acute articular rheumatism, with pain, redness, swelling, tenderness, and disability. But there are no sweats. The brilliant redness and exquisite sensitiveness of acute articular rheumatism are not seen, and fever is relatively slight. A subacute onset varies in intensity from a mere ache with local tenderness to a moderately severe pain with some swelling and considerable disability. The duration of the inflammation is characteristically prolonged, although exceptionally an intense attack is brief. The mildest lesion may hang on for weeks and months. The severity of the inflammation is moderate as compared to other types of septic arthritis. There is more or less thickening of the soft tissues and usually no great exudation within the joint. Yet, exceptionally, the joint may be filled with a purulent exudate and be the cause of intense sepsis. Complications. The complications due to direct extension from the joint are bursitis, tenosynovitis, and infiltrations of the surrounding tissues. Abscess outside the joint, as in the case reported by Ware, is even rarer than suppurative arthritis. Implication of the bone is, as stated above, primary and not secondary. The results of gonorrheal arthritis depend upon the treatment and the nature of the lesion. Osteoarthritis may even result in total destruction of the joint with bony ankylosis. The worst that simple arthritis can do is to cause fibrous ankylosis. The most discouraging features of the prognosis are the marked tendency to chronicity and the tendency to relapse after apparent cure. Diagnosis. The diagnosis of acute gonorrheal rheumatism occurring during the course of gonorrhea is not difficult. Under these circumstances, marked swelling in a joint with slight constitutional disturbances is very suspicious. A positive complement fixation test for gonococcus confirms the diagnosis. The para-articular involvement gives the swelling a characteristic fusiform shape. Acute gonorrheal rheumatism occurring in the absence of gonococcic urethral lesion, as in the children reported by Kimball, may be diagnosed by the complement fixation test or by identification of the gonococcus in the fluid aspirated from the joint. But this fluid, whether serous, serofibrous, or purulent, is usually quite sterile. Chronic gonorrheal arthritis must be differentiated by the complement fixation test from other forms of septic arthritis. Nathan insists that though gonorrheal arthritis may be recurrent, it is never really chronic, and that the cases called chronic, quote, are those in which the initial acute inflammation has left behind bands of adhesion or other structural change in the synovial membrane in arthritis, and bone outgrowths or ankylosis in osteoarthritis. These changes, unless treated mechanically or by operation, are permanent, end quote. Prophylaxis. Among the gonorrheal patients I have treated from the onset of their disease, not one has developed systemic gonorrhea. This is in a measure the dispensation of a kind providence, but it is primarily a result of the proper treatment of the disease in its early stages. The local treatment of acute gonorrhea almost certainly prevents systemic gonorrhea. The injection of vaccines at the first appearance of the fever in the course of a gonorrhea also has a prophylactic effect. Curative treatment. Inasmuch as acute gonorrheal arthritis is but one lesion in a general systemic infection, the patient should be considered septic, and the possibility of further systemic gonorrhea should be recognized. He should be put to bed and the urethral source of infection vigorously attacked. Inasmuch as the seminal vesicles are believed to be the usual source of infection, these glands should be massaged. The precise status of vesiculotomy in the treatment of gonorrheal rheumatism is not yet precisely defined. It unquestionably cures some cases and fails to cure others. Page 245. The joint should be immobilized and beer hyperemia employed throughout the acute stage. A light plaster of Paris bandage or splint affords the best immobilization and does not interfere with the beer treatment. The patient should not be permitted to use the affected limb before the acute inflammation has subsided, however mild this be. The one way to prevent permanent changes in and about the joint is by careful local treatment during the acute stages. The beneficial effect of the beer treatment cannot be doubted. The specific vaccines in sera afford little relief, page 114. One or the other should always be employed. Quote, hot air, baking has much the same effect as the beer treatment. If the tension within the joint is not promptly relieved by immobilization and passive hyperemia, the fluid should be aspirated. The presence of pus in the joint is not of itself an indication for more vigorous surgical measures, for it is likely to be spontaneously absorbed. But if the pus persist, arthrotomy should be performed and the joint irrigated with 1 to 2,000 nitrate of silver solution. As the acute symptoms subside, the diagnosis should be accurately made between arthritis and osteoarthritis. The former requires that the immobilization be prolonged and passive motion begun cautiously. The latter, that passive motion should be begun early, before the splint is left off, and that massage, passive motion, and splints be used until function is entirely restored. Exostosis of the os calcis. Though first described as recently as 1906 by Bayer, this condition is so common and so painful as to merit special mention. It begins as a myositis or periostitis at the attachment of the flexor brevis digitorum to the tubercle of the os calcis. With the subsidence of the acute inflammation and exostosis forms, pressure upon which, in walking, is exquisitely painful. The diagnosis is made by radiography. The treatment is operation. The exostosis must be chiseled or scraped away after exposure through an incision along the inner side of the heel.